Good morning. It's nice to be back here, introducing another of my favorite people. So, it is my pleasure today to introduce my friend and colleague, Dr. Jennifer Cruz, as our grand round speaker. Jen is a health sciences, as top of her class at Mayo Medical School, etc. And then we were lucky enough to get her as a resident here, which is, of course, where many of us got to know her. Many of you may remember Mark Fry, one of our former residents, then one of our former faculty members, who then went back to Mayo. And when he was at Mayo and Jen was just finishing medical school, he called me and said, "You have our star coming for to your residency. Please look for her, watch out for her." I did, not that Jen needed me to do so. I was privileged to have her work in the mood disorders clinic while she was a resident, and she became passionate about the consultation service, mind-body, brain-body interactions, and was a chief resident in CL. And then Mark calls me again and says, "Look, I'm recruiting Jen to come back to Mayo for a psychosomatic fellowship, but I promise you it's only a year and she can come back to UCLA afterwards." I threatened to harm him if he reneged on our deal, and he didn't renege on the deal. Jen went back for a year, and sure enough, then we recruited her back here to be on the faculty. And as I said before, she's just been a star in CL. Even though Jen, who's now also an attending in the mood clinic, is a gifted clinician and a gifted teacher, she's also been passionate about research. As a senior resident and then in her fellowship, she became increasingly interested in psychoneuroimmunology, and she's spent the last number of years working with Mike Irwin, and just recently she got a K Award, a K23 from the NIH, which is about as prestigious a junior research award as you can get in the United States. Her basic field is PNI, the role of inflammation in mood and mood disorders. But today, she's going to be talking about something else. I asked her how she became interested, and when she was, I guess, a resident, she had a case of NMDA receptor encephalitis, and so she became interested in the glutamate system. By that, became interested in ketamine, and that's been a real interest of hers. So she is going to talk to us, give us an update on where we are about ketamine, both biologically and clinically. A great pleasure to introduce my friend, Dr. Jennifer Cruz.
Thank you for the introduction. We have a lot of ground to cover today, so I'm going to just jump right in. I don't have any financial disclosures. The primary learning objectives today. At the end of this talk, what I'm hoping you'll be able to do is, one, describe the evidence supporting the use of ketamine for depression, or S-ketamine, and describe how and when to use ketamine for depressed patients. In order to get there, there are a number of things that we'll talk about. First, we'll touch a little bit just on depression and the limitations of the monoamine treatment strategies, the monoamine hypothesis for the treatment of depression. We'll talk about ketamine and how ketamine represents a new mechanism in terms of antidepressant pharmacology, as well as the new challenges that come along with ketamine. We will review the ketamine and S-ketamine efficacy studies, and then really focus on ketamine clinical use. For whom and how do you use ketamine clinically? We'll touch a bit on future directions also. So, I'm preaching to the choir a bit in this room. Most of us here have struggled alongside our patients in trying to get them well. So treatment-resistant depression is a very common clinical disorder that we encounter on a daily basis as psychiatrists, therapists, etc. And for the antidepressants that we have, when they work, it takes several weeks for them to work. We know from STAR-D data, which I will talk about a bit more in a moment, that within the first trial of treatment, less than half of patients will get better, and that after multiple different pharmacological trials, still a third of patients will remain depressed. Depression is the leading cause of disability worldwide, and there are obviously innumerable benefits of getting people better and getting them better faster. So the monoamine hypothesis, our existing antidepressant pharmacology primarily focuses on serotonin, norepinephrine, dopamine, sort of agents that can alter the synaptic concentrations of these agents. Many of us will remember this advertisement from about 2 decades ago now, where you can see on the left side there's a sad blob who doesn't have enough serotonin in his synapse, and then on the right side you have a happy blob because he now has enough serotonin in his synapse. And obviously, it's much more complicated, probably the way that these agents are really working with the downstream effects mattering. But the point being that these drugs that have that sort of simple idea behind them haven't proven to be good enough for our patients, although they are for some. So in the STAR-D data, where thousands of patients participated in a number of steps of treatment, after the first treatment step, about a third of patients remitted and not even half responded. So for those of you who may not be familiar with sort of the definition of response in clinical research, that is a reduction in your depressive symptoms by at least 1/2. And then as they moved to the second step of treatment, about another third remitted. But then when you got past those first 2 steps, the remission and response rates were increasingly worse. So at step 3, only 14% remitted, and then at step 4, only 13%. And so the cumulative estimated remission in this study was 67%, leaving a third of patients treatment refractory after 4 different pharmacological trials. So that's just, not great. And even those who did get well didn't stay well in a sustained way. So, and that depended upon how many trials it took to get them well. So the purple line here are those who got well with the first step of treatment, and you can see that by about 12 months, about half of those patients had relapsed, and then this line represents those who took 4 trials to get better, and you can see that about half of patients had relapsed by about the 4-month mark. So that's disappointing. To touch on bipolar depression, we obviously have an expert here in the audience on bipolar depression, Dr. Michael Gitlin. This represents just one of many studies evaluating antidepressant efficacy in bipolar disorder. This was the STEP BD study. And in this study, patients who were on a mood stabilizer and either an antidepressant, bupropion or paroxetine, or placebo, had equivalent responses. Their primary endpoint was defined as durable recovery, which was 8 weeks of euthymia. So it's not great. I don't think anyone in this room thought that monoamines were the solution to all of the problems that depression brings. There's just some of the data to demonstrate that. So I thought, hey, we're in LA. I tried to make kind of like a dramatic title slide here. Could you see that on buses or billboards around? I don't know. So let's talk a bit about ketamine. So there's really been a tremendous amount of excitement and hope related to ketamine research. It represents a novel mechanism, which we'll get into more detail on shortly, and it's fast-acting. So unlike our typical antidepressant strategies, patients who receive treatment with ketamine often enter response or remission within hours to a day of treatment. So that's a really big advance. And it's been found to be effective in treatment-resistant depressed patients at high rates, like 50 to 70%. So if you compare that to step 3 and 4 of the STAR-D data, that's really a remarkable increase in terms of rates of response. So we'll do a little whirlwind tour here of ketamine as an antidepressant. So the first pilot study for ketamine use in depression was published in 2000 in Biological Psychiatry, and they had 7 patients. They did a randomized controlled crossover study, and they had really remarkable results for ketamine versus placebo. And that sparked many, many more studies at many institutions and much excitement about ketamine, with demonstration of efficacy in meta-analyses as well. And also led to many docs beginning to prescribe off-label ketamine in the community, which we'll also touch on. And then finally, most recently, last month, the FDA reviewed and approved S-ketamine intranasal spray for the treatment of treatment-resistant depression. There's the whirlwind tour. We'll get into more detail here. So first, how does ketamine work? So it's complicated. It's not the same old monoamine strategy. The focus is really on glutamate neurotransmission. And glutamate is the most abundant excitatory neurotransmitter in the brain. And there are a number of different glutamate receptors. There are metabotropic receptors, so glutamate binds and an enzymatic process is initiated. And then there are ionotropic receptors, so ligand-gated channels that when ketamine, sometimes with a co-receptor bind, opens an ion channel. The receptors of sort of most interest as it relates to ketamine are the NMDA receptor and the AMPA receptor. So what we know is that ketamine is a potent NMDA receptor antagonist, but it's probably not so simple. So many groups who are doing preclinical work and really trying to sort out the molecular neurobiological mechanisms of how ketamine is working are finding some really nuanced results as it relates to which metabolites of ketamine may be most important, or is it ketamine itself? Which receptors are actually required for the benefits of ketamine on antidepressant-like behavior in animals? And it's actually, the story is becoming sort of increasingly nuanced. Also, many other NMDA receptor antagonists have failed to demonstrate antidepressant effects, and certainly not the robust and rapid ones that are seen with ketamine. So it's probably not just the NMDA receptor antagonist mechanism that is the key. So the overarching theme of what this field believes is probably happening to elicit an antidepressant response relates to synaptic plasticity. So there are a number of different sort of conceptual models from how we get to ketamine, step A, to the synaptic plasticity, including NMDA blockade resulting in a cascade, including increased glutamate neurotransmission, activation of AMPA receptors, and increase in mTOR activity, BDNF, brain-derived neurotrophic factor expression. So we won't get too much in the weeds on this, except to mention that, as I kind of alluded to previously, there was a group who found that metabolite of ketamine could result in the same antidepressant effects, completely independent of the NMDA receptor. And there's actually been another group that's shown that even the AMPA receptor may not even be required. So it's unclear, like those direct molecular pathways. But again, the end result being this idea of enhanced plasticity. And really what that means is like the growth of neurons, new synapses, new dendritic spines that we know in models of depression and stress actually kind of atrophy, pull back. Okay. And then I have to mention there was a new study on mechanisms of ketamine that was published in Science. You might have heard of it. Last week. And the title of this is Sustained Rescue of Prefrontal Circuit Dysfunction by Antidepressant-Induced Spine Formation. So it's a really complicated, really elegant study using really remarkable technology. But the sort of take home was that it did confirm this plasticity, this growth of dendritic spines in response to ketamine, and also found that even preceding this, there was a restoration in circuit function in the animals studied. And that restoration in circuit function correlated with the time course of restoration of behavior, but that the dendritic spine formation was required in order to sustain the antidepressant-like effect. So the main point being here that it's not a clear, open and shut case in terms of how ketamine is working mechanistically. There's a lot of really cutting-edge research ongoing to try to sort that out. So let's talk about the human efficacy studies. So these first couple of slides will focus on IV ketamine. And as I mentioned, there have been a lot of studies published in the last 2 decades, but really not that many randomized controlled studies. I think they're somewhere in the range of 10. And most of these studies don't have huge sample sizes, but they are finding consistently robust effects of ketamine, including meta-analyses of those randomized controlled trials. And then, as I mentioned, there are lots and lots of open-label studies looking at the response and remission rates and ketamine use. You know, I do have this sort of bottom point here, which I should mention. So ketamine is incredibly cheap. It's been FDA approved for decades as an anesthetic, and we're not ever going to see really large-scale clinical trials of ketamine itself, as there's really no financial incentive for a company to fund those large randomized trials, since there would be no patent for it. Okay, how about for bipolar depression? So the results in bipolar depression actually have been encouraging. It's just that there's not much data. So there have been, that I'm aware of, 2 randomized controlled trials of bipolar depression patients, and in both of those studies there was improvement in depressive symptoms through day 3, followed up to day 14. And then many of the studies, including the research studies here at UCLA on the use of ketamine, enroll bipolar depressed patients as part of their sample, but aren't powered to, evaluate the differential effects in bipolar depression versus unipolar depression. And then one meta-analysis, again, it's very limited data to draw from, but what they concluded was that it could be in bipolar depression that though there's good acute response, the response may not be as durable as in unipolar depression, with response sort of falling off by day 3, whereas in unipolar depression, usually with an infusion, there's still a separation from placebo at day 7. How about specific symptom profiles or specific symptoms? There's been a lot of interest in the use of ketamine for suicidality specifically. There was a meta-analysis of depressed patients in randomized controlled studies who had suicidal ideation at baseline, and again they found really robust results in terms of reductions in suicidal thinking starting at day 1 and persisting through day 7. And then also those of us who are really doing a lot of work in depression know that anxious depression has been shown to be harder to treat than non-anxious depression. And so one group looked at whether ketamine had a differential impact on either of those groups. And what they found, again, it's one study, but they found that ketamine was equally effective in a sample of anxious versus non-anxious depressed patients. And then another study specifically was just looking at how ketamine did in terms of reducing anhedonia. That was a bipolar sample, I believe, and found that ketamine does, in that sample, reduce anhedonia, which again is a symptom that can be more recalcitrant to treatment. So that's a bit about IV ketamine, but that's not the only route for which ketamine can be administered. So I'm not going to go into too much detail on the existing studies of oral or sublingual forms. I will just mention that There have been some positive open label trials of both sublingual and oral ketamine, and I'm aware of one small-ish randomized controlled trial of oral ketamine, daily treatment with oral ketamine for 28 days that did separate from their comparator, which was an NSAID. Actually, it was a group of depressed patients who also had chronic pain. So depression did better in the ketamine group. But what I will really focus on now is the S-ketamine intranasal spray. Obviously, this is newly FDA approved, and so a lot of people are trying to figure out how and if to incorporate this into their practices. So let me review the data on that and sort of the logistics. So S-ketamine, actually let me back up. Ketamine is a racemic mixture of the R enantiomer and the S enantiomer of ketamine. So it's been found that the S enantiomer is much a more potent inhibitor of the NMDA receptor. And so it was chosen to be developed as an antidepressant treatment as that more potent NMDA receptor antagonist. And to jump to the punchline, as we've already mentioned, it was FDA approved last March for the treatment of treatment-resistant depression. 4 controlled trials were submitted with the FDA application for phase 3 ones. In all of the studies, the patients had to have failed at least 2 trials of an antidepressant. They actually entered the trials on an antidepressant, were monitored prospectively to ensure that they weren't responding to that, and then were all switched to a new oral antidepressant and either intranasal S-ketamine or intranasal placebo. There were 3 short-term efficacy studies and 1 maintenance study. One of the short-term efficacy studies was positive, and the maintenance study was positive. There's some nuance there we'll get to shortly. So we'll talk about the 2 significant studies first. So in this study, you can sort of clearly see the separation from placebo. Obviously, both groups are getting a lot better. Both groups are also getting a new antidepressant at the same time, and they have a separation throughout most of the duration of the trials, certainly by day 2 and at day 28. And then the maintenance study, patients who had responded to S-ketamine intranasal spray together with their oral antidepressant were then put in sort of an optimization phase where they continued that treatment for several weeks and then were randomized to either continue their S-ketamine intranasal spray or to have that switched out for a placebo. And you can see from the survival curve that pretty rapidly there was a quite marked separation from placebo. So, and here are the 2 non-significant trials. The reason I kind of wanted to mention this Transform 1 trial in particular is because they actually had 3 groups. They put people either on placebo, the 56 milligram dose of S-ketamine, or the 84 milligram dose of S-ketamine as their phase 2 studies had demonstrated like a dose response curve. And so the expectation was that the 84 milligram dose would perform best. And so that was the primary endpoint, and it was like a fixed order of analysis, so that if that first primary endpoint was not significant, then the trial was not significant, and none of the other endpoints sort of mattered. So the reason I'm explaining all of this is because actually the 56 milligram dose of S-ketamine did separate from placebo in this trial, though it is overall considered to be a negative trial. And then the geriatric study was not significant. So, so there's some of the efficacy data. What are the challenges and the limitations of ketamine treatment? So there are quite a few, actually. So Ketamine is a dissociative agent. It has psychotomimetic side effects. It has sedation as a side effect. It has risk of abuse and dependence. It causes some cardiovascular perturbations, including elevations in blood pressure and tachycardia. And there are concerns about possible long-term issues such as impact on cognition as well as cystitis. And these latter two concerns are informed by recreational abusers of ketamine who not uncommonly develop a severe bladder condition, either interstitial cystitis or hemorrhagic cystitis, and have been shown to have cognitive effects with using high doses recreationally abused ketamine. And then there's been a unique issue related to ketamine in that it's readily available off-label. And so, as initial studies are coming out and people are sort of opening up clinics, it's sort of like the cat's out of the bag before we, as a field, really had the opportunity to sort out what the risk may be, what an appropriate treatment protocol might look like, all of that sort of practical information. So, as we all surely know in this room, there are really hundreds of clinics throughout the nation who are providing IV ketamine for depressed patients. And there are also many people who are prescribing ketamine through compounding pharmacies. So ketamine is very inexpensive. It comes in a liquid form as an anesthetic, but then can be compounded in compounding pharmacies into tablets, into lozenges, intranasal spray, etc. And so there are many clinicians who are using ketamine in that way also. And there's been a lot of controversy as this has developed in the field. There's been concern that we could be sparking a new substance abuse epidemic by the increased availability of ketamine. There's one group that has great concern that ketamine may in some way be working through the opioid system, and is there a risk for sort of a cross addiction to opiates with the use of ketamine? Are we opening Pandora's box? And then the alternate viewpoint, which is sort of, I believe, more pragmatic, is we're already there. We can't put the genie back in the bottle. Now we sort of need to sort of figure out how to safely and responsibly treat our patients and manage potential risk. So with regard to that risk, I think that this is an informative case report. It was published in the American Journal of Psychiatry in 2017. And it was this 52-year-old gentleman with treatment-resistant depression, remote history of an alcohol use disorder, who was first admitted to the hospital that the authors are from in 2012, and treated with the ECT at that point after he was determined to have failed multiple pharmacologic treatment trials. Then came back about a year later, again with suicidal ideation, had a return of alcohol use, but not identified as problematic, 1 to 2 a day, but was misusing lorazepam, 5 milligrams a day, and had recently been prescribed intranasal ketamine from an out-of-state neurologist. And the reason that he sought this out is because he had actually participated in a ketamine research study. He had a single infusion of IV ketamine. He had a good antidepressant response to it, and so then he sought a ketamine prescriber. 3 months after that admission, he was again readmitted and was using more alcohol, reporting about 4 drinks a day at that point, and using his intranasal ketamine 10 to 12 times a day. So his family was very concerned. His perspective was that, this keeps me well, it's the only thing that helps me. The family says he's like constantly intoxicated basically, and he was still driving, and they thought it was ruining his life. 1 month later, he was admitted after a suicide attempt after he'd run out of ketamine. The team had contacted the out-of-state neurologist, asked him to stop prescribing given the abuse, and then 3 months after that, he unfortunately died in a single car crash, which his family believed was a suicide attempt facilitated by alcohol. So, it's a very extreme example, but I think an important cautionary tale to just sort of have in your mind like the worst case scenario in this type of thing. So we'll take a moment to talk about abuse and dependence of ketamine. So it is a Schedule III controlled substance, comes in a liquid form, it's boiled down into a powder, then can be injected, snorted, smoked, or swallowed. It is most commonly abused in nightclubs, at parties. Some people do develop daily use and dependence. The desired effects of ketamine is sort of this sense of floating, change perception of sight and sound, kind of a feeling of detachment from the self and the environment. And it's recreationally used doses are usually about 1 to 2 milligrams per kilogram, in a bolus. So it's about 2 to 4 times higher the total dose of the IV ketamine that's infused over a period of 40 minutes. And as I mentioned, some do develop daily use dependence. There is tolerance associated with daily use. In terms of statistics, how much of a problem is this here? The Monitoring the Future report that does surveys of adolescents each year found that, despite the increased availability of ketamine in terms of treatment, clinics and things like that, the use is at historic lows among 12th graders, with 0.7% of all 12th graders reporting use in the past year. And then of all U.S. adults all U.S. persons older than 12, 1.3% report lifetime use at any point. So not super high rates for sure. Interestingly, this has been kind of a big problem in China and other Asian countries. Among substance users who are seeking treatment, for 34% of those patients, ketamine is the primary substance of abuse that they're seeking treatment for. And among a similar population of youth drug users that are encountered either in the health system or by the police system, 80% had reported use of ketamine at some point. Now, not necessarily the primary substance of abuse, but it's more common there, to the extent that China has actually asked the World Health Organization to ban the production of ketamine throughout the world. It's been quite an issue for them. And then there is a recent article in The Guardian that indicated that police seizures, which is one sort of measure of how much a substance is being abused, had increased 30% in the last year in the UK. So that suggests, at least there's sort of an increase in use. And again, this is usually in youth culture. So, but like I said, what's the thing about the genie in the bottle? This is a few articles from the media. Most of these articles, and there are many, many more, those are just some of the prettier or ones from major media outlets. Most feature an anecdote of a patient whose life has been completely turned around by ketamine. They struggled with treatment-resistant depression, and now they're, working and, present with their children, et cetera, et cetera, et cetera. And the blogosphere is also, full of these type of anecdotes. And so this is out there. There's no turning back time. So though these risks really are real, they exist, ketamine isn't going away, and it's really clearly helping a lot of people who have suffered for a long time. And so, as I mentioned earlier, kind of how do we manage it? So I think that's a good segue to talk about sort of common adverse reactions. And I just think we're kind of, we really benefit from the large trials completed for S-ketamine intranasal spray in terms of better understanding the common adverse reactions to at least S-ketamine, which I think to some extent can be generalized to ketamine. So dissociation, I'm not going to go through all of these, but the three bolded adverse reactions here are sort of the most concerning, and the reason that, one major reason that there's a thorough REMS program developed for this drug. So we'll talk about dissociation first. So Uh, 61 to 75% of patients in the S-ketamine intranasal studies developed some symptoms of dissociation. I'll make sort of a little side note here. There has been a question about whether or not dissociation is required for the medication to be effective, and the studies evaluating that are mixed. Some say no, and then others with a larger N say that yes, there does seem to be a strong association between dissociation and antidepressant response. But even if those two things are associated, it's I believe, difficult to interpret that association. Maybe it sort of represents like an adequate, like some CNS dose, or maybe a vulnerability to the dissociative symptoms also underlies like a propensity for the treatment response. I'm not sure. And anecdotal clinician experience varies. So, you know, I am not personally convinced that let me take a step back. So unlike some of the studies, for example, of psilocybin for existential depression or existential distress at the end of life, people aren't, in my clinical experience doing ketamine infusions, aren't having like a spiritual journey that then is sort of informing their treatment response. Most of the patients that I've treated have said, oh, it's kind of weird, and aren't super enthusiastic themselves about the experience. So I don't, my belief is that sort of a spiritual type journey or a high is not really like mediating the effect, though the two certainly could be associated. And then also in support of that, so the Mayo studies on ketamine dosing are really, really conservative. And they do the same overall dose of ketamine, but infused over 100 minutes instead of over 40 minutes in order to minimize the dissociative effects. And they found similar results to the other groups in terms of response rates. So there's that. But regardless, dissociation means that patients need to be monitored. So you don't want people, you know, just dissociating out in the community, right? Or maybe, I don't know. Sedation. So some degree of sedation occurred in 50 to 60% of patients, and in all of the S-ketamine intranasal spray studies, which represented over 1,000 patients, there was severe sedation. 2 of those patients actually had loss of consciousness, defined by the scale below, in which there's no response to even a painful stimulus. So again, very small number there, but it happened a couple of times. And in almost all cases, the sedation completely resolved within 2 hours following administration of the dose. Blood pressure is the other sort of major risk in terms of need for monitoring. In the intranasal S-ketamine studies, generally the highest measurement was at 40 minutes following the administration. And it was fairly common to have increases, even fairly substantial increases. 8 to 17% had greater than 40 millimeters of mercury increase in their systolic blood pressure, or 25 the diastolic blood pressure. And so kind of some take-homes of this is that blood pressure really needs to be controlled prior to considering S-ketamine treatment, and needs to be monitored throughout an IV infusion and throughout the intranasal S-ketamine infusion. The recommendations and requirements for monitoring and the intranasal S-ketamine REMS program include documenting baseline blood pressure, documenting blood pressure at 40 minutes, and documenting blood pressure prior to discharge. That documentation is all faxed to the manufacturer. So keeping all of those potential concerns, side effects, et cetera, in mind, how does one safely use ketamine or S-ketamine in clinical practice? In the American Journal of Psychiatry in 2017, a group of mood disorders experts got together and wrote a consensus statement on the use of ketamine in the treatment of mood disorders. So I think, you know, this is like a fairly brief document, and I think if you're, you know, really thinking about incorporating ketamine into your practice, I think it'd be wise to kind of review this document to kind of get a basic guideline. It is a very conservative document. The basics, full history, full physical, full review of systems, making sure you're identifying any potential medical comorbidities that could increase the patient's risk when exposed to ketamine. They suggest a detailed evaluation of psychiatric history and treatment failures, including review of medical records, and if those are absent, confirming collateral with family to make sure that the patient is a reliable reporter. Obviously included in that is substance use history to identify risks related to substance abuse and dependence. They suggest a urine toxicology screen and a written informed consent process with patients. And they suggest for setting, someplace where you have the means to monitor EKG, vital signs, where you can deliver oxygen, apply restraints, an established plan to provide advanced cardiac life support or transfer to a hospital capable of doing so. And they suggest that an ACLS certified clinician is present at the time of the infusion. Dosage and frequency, they recommend 0.5 milligrams per kilogram over 40 minutes. This is what most research studies have done for ketamine, with a consideration of dose adjustment for those with a BMI greater than 30. And suggest a maximum of twice weekly dosing for up to 4 weeks, with discontinuation if by the second month of treatment the dosing can't be reduced to once a week or less. Recommend monitoring for the emergence of substance use disorders, including a recommendation that the patient should never have access to ketamine at home, including recommendation for intermittent urine toxicology screens, and regular queries regarding patient attempts to seek ketamine elsewhere, as well as utilizing the prescription drug monitoring program, such as Kruse here in California. So those are some guidelines for IV ketamine, and I think, if considering intranasal lozenges, et cetera, I think this also is just a nice conservative guideline, so you can see what experts sort of came together to suggest. It's not rigid, but I think helpful. And then, what are the pragmatics of prescribing intranasal S-ketamine? Well, first, the FDA has approved a risk evaluation and mitigation strategy for intranasal S-ketamine. The key elements of this are that S-ketamine can only be administered in a healthcare setting, that the patient must be monitored in that setting for at least a minimum of 2 hours after administration, that the drug is never dispensed directly to patients, and that patients must be enrolled in a registry to better characterize the risks associated with S-ketamine throughout the duration that they're being treated with it. So there are 3 essential pieces of the REMS in terms of who must be enrolled. So the healthcare setting must be enrolled. The pharmacy dispensing the medication must be enrolled in the S-ketamine REMS, and the patient must be enrolled. There's really very helpful, detailed information available on the manufacturer website. That website, if you are interested in reviewing it, is spravadorems.com. And they also there have for review the forms, like how to enroll each patient, what are the monitoring forms that must be submitted after each treatment session, etc. So what are the logistics? So once everyone is enrolled in the REMS program, the medication can be prescribed through an enrolled pharmacy. The pharmacy must then deliver that drug to the healthcare setting, and then the patient self-administers the intranasal S-ketamine monitored in the healthcare setting, where they then are stayed and monitored for at least 2 hours or longer if they are still having marked blood pressure changes, sedation, dissociation, etc. The recommended starting dose is 56 milligrams. Each device has 28 milligrams, so the starting dose is 2 of those devices. And then subsequently, per clinician discretion, continuing the 56 milligrams or going up to the 84 milligram dose, which would be 3 devices. The induction phase recommendation is to have the treatment twice weekly for the first 4 weeks, and then for the following 4 weeks to have it once weekly, and then after that individualized with the minimum frequency required to maintain the response. The cost is listed there, and some insurers have started to cover this with prior authorization. How about ongoing off-label ketamine? So as we discussed, ketamine prescribing is ongoing in clinics and through compounding pharmacies. And as I mentioned, for IV ketamine, my suggestion would be to use as suggested in the consensus statement with caution, good monitoring practices, obviously. For the nasal spray, if people are using that through compounding pharmacies, I think I think the guidance we have from the FDA is really informative on the intranasal S-ketamine in terms of the patient never taking this substance home, being monitored, et cetera. And, to link back to that sort of cautionary tale, that's not going to be everybody. That's kind of on the extreme end. But there is certainly risk involved in sending, patients ketamine to have home with them in their medicine chest. So I would say it's highly advisable to have treatment supervised and to basically, for all formulations of ketamine, the goal is to protect your patients and also to protect your license, right? So future directions, S-ketamine is also, S-ketamine intranasal spray is pending FDA review for MDD, major depression with imminent risk of suicide. That's anticipated in around 6 to 8 months to be reviewed. And then, where will ketamine fit? Maybe it will be an accelerating agent. So people maybe won't be treatment refractory at some point, and 10 years from now it will be common to have a intranasal 1 dose of ketamine in office and then maintenance on their Prozac or whatever. Who knows? I don't know what the future holds, but I think there's a lot of possibilities. As long as sort of we all are working cautiously towards helping patients. And then, of course, under development are other glutamate modulating pharmacotherapies. So there's certainly a goal to look for sort of simpler administration of an agent that doesn't have the adverse side effect profile that S-ketamine or ketamine does. Then I just want to also mention the UCLA and VA clinical and research programs. So Randall Espinosa has been leading a clinical ketamine service here at UCLA since 2010, and those infusions are done in the ECT suite. And many in the Jerry division also participate and help with that. And there's a clinical ketamine service that's recently been initiated at the VA, led by Dr. Dunn, and Scott Fears also is involved with that. Also, I should note, this slide kind of indicates there's a lot of local expertise on this topic. So certainly reach out to any of these people with questions about it. But Dr. Dunn was actually served on the FDA advisory committee that voted to approve intranasal S-ketamine. Side note. And then in terms of research, Drs. Catherine Nahr and Randall Espinosa have for years been collaborating to lead studies on better understanding the mechanisms of ketamine treatment response. So I threw the contact numbers up there if anyone's interested in the research study, and I hope I didn't put the wrong person for the clinical service, but I think it's right. So in summary, ketamine really offers promising advances in depression research. Really exciting time to be in depression research with ketamine. Also offers promising advances for our patients. There are many basic science and clinical questions that are remaining, and there are certainly limitations with regard to abuse potential, dissociative side effects, sedation, blood pressure effects. But clinical use of ketamine and S-ketamine is available, and sort of the take-home is, take this information, exercise caution, you do careful patient selection and monitoring, and cautious optimism for our patients suffering. A few acknowledgments. I'm lucky to have very, very many wonderful mentors here, both clinically and from a research perspective. and a few of those are listed here, as well as members of the research team and the clinical teams providing ketamine treatment here at UCLA or at the VA. And then a special acknowledgement to my husband, Kiddo Wrangler, and a gratuitous photo of them for, applause. So, anyway. Comments, questions, discussion?
I was curious about patients who have MDD with psychotic features, and if they,
Yeah,
you get it, yeah.
Yeah, I do. It's a great question. So those patients are pretty much universally excluded in all research studies. So we don't know much about them. There have been a couple of case reports in the literature of patients getting benefit who have MDD with psychotic features. I would say if it were my patient, I would sort of very carefully consider it, like what kind of psychosocial supports might be around, that sort of thing. There's obviously concerns of worsening any sort of psychotic process, right? And so, I would err on the side of probably not the best idea, but maybe in particular clinical circumstances you would consider it. But we don't know enough, basically, is the bottom line.
Just given the way that ketamine might work on the brain and the case study that you presented, and also kind of how readily available it is, for patients who are recovering from substance use disorder and also have depression and are just kind of like looking for the next treatment, is it not really advisable for them to even seek out ketamine? Will doctors kind of turn them away for that? Just kind of what is the sentiment towards that?
Yeah, it's a really important question, and I think one that, again, we don't have clear answers to. However, there is a group at Yale who recently studied in patients with alcohol use disorders and major depression, co-administration of naltrexone and ketamine, and they had really good responses in terms of depression. So I think it is a question that people are working on. There's obviously a very high comorbidity of substance use and depression, and so I certainly wouldn't say that patients should not be considered for ketamine treatment just because they have a history of substance use. But I would consider sort of the duration of sobriety. I would be incredibly wary to prescribe ketamine to somebody who had an active substance use disorder. That's my thought.
Thanks for your talk. Do we have enough information available to determine if IV ketamine is more efficacious than intranasal administration?
No.
Is it suspected that might be the case?
Response rates are similar in studies, and there's been no head-to-head comparison that I'm aware of. The issue that I didn't mention with the different dosing formulations is, this idea of bioavailability, right? So, oral ketamine, the bioavailability is somewhere around maybe 15-ish%, 10 to 20, I think are the estimates. Intranasally, it's estimated to be like 60 to 70%. So, getting close to approaching the 100% bioavailability of the IV formulation. There's still, a lot unknown about whether S-ketamine, R-ketamine, or the racemic mixture may be more effective. So there are a lot of unknowns. But based on my read, I'm not sort of clearly convinced or even really suspect that one is superior to the other based on the available data. We might find that out. I hope we do.
Hi, so I have a question. Thank you for a great talk. I'm curious about the mechanism of ketamine. It seems that we assume it's through NMDA inhibition, but my understanding is memantine, which is a more specific clean NMDA inhibitor, doesn't seem to have antidepressant effects. So I'm curious whether there are alternative mechanisms to explain how ketamine works.
Yeah. So So yeah, it's probably not that simple. So as you mentioned, other NMDA receptor antagonists haven't been shown to have antidepressant properties, and there's probably a lot of nuance in terms of what metabolites are the most important ones, what actual receptors they may be working through, whether it's AMPA, and how they sort of ultimately lead to this final common pathway of increased plasticity, which is how most actually believe that ketamine is working.
And that's all the time we have for questions for right now, but if you have any questions, feel free to come up and chat with Dr. Cruz. Thank you.